Hello. Hello. Good evening, friends. Today we are going to have a CME on hepatocellular carcinoma. So I have great pleasure in welcoming all of you here this evening. There's been a lot of progress made in the pharmacotherapy, immunotherapy, surgical concepts of hepatocellular carcinoma. So we have to keep ourselves updated with whatever is new. Our plan is to discuss 4 lectures, which each will be of 20 minutes. And I request the chairpersons to have the questions at the end so that there will not be any overlap. So 20 minutes, that will be 1.5 hour session, followed by 2 case scenarios will be discussed by Dr. Mayur and Dr. Rajesh. So may I invite the chairpersons for this, Dr. Amit Gulane, Dr. Sushil Mandhaniya, Dr. Mohan, and who else? Dr. Rahul Saxena is not there. Dr. Snehal. Dr. Snehal has recently joined as a gastroenterologist in CARE Hospital. So with this, I hand over the mic to the chairpersons for further proceedings. Thank you.
Good evening, all. Without wasting time, I think we should start the session. The first one is a changing trend in HCC paradigm. How can we push the envelope further? This is by a gastroenterologist, Dr. Bhushan Bhaware.
Hello. Start. Good evening to all my respected chairpersons and my fellow colleagues. Yes, today we are gathered together for this nice MDT, which has been held by Dr. Mukewar sirs. And my today's topic of discussion regarding an overview or changing trends in hepatocellular carcinoma. As you all know that the global burden of a disease, which was issued by WHO in 2020, just found that the liver cancers representing nearly 4.7% of all cancer diagnosis, and it's the 6th most common cancer overall. It also found that you all know that it is more commoner in males than in females. It has seen that in 2020, the number of new cases in both the sexes of all ages was approaching towards 1 million. Similarly, the global burden of disease also seen that liver cancer is the 3rd leading cause of mortality, which is accounting to 8.3% of cancer deaths. And number of deaths which has reported in 2020 in all sexes were nearly around 8 lakhs. It's accounting around 8.3% of all the liver cancer mortality. This was issued in global burden of disease in the WHO ARC curve. It also showed that report that the global incidence of liver cancer is gradually increasing in the developing countries rather than the well-developed countries. It might be reason for in developing countries, developed countries is better availability of anti-HCV treatment coming up, and which is slowly decreasing their incidence of liver cancer in HCC. As you all know that HCC accounts for more about 90% of all liver cancers, and rest of the 10 cancers accounts like cholangiocarcinoma, angiocarcinoma, and hepatoblastoma. As you all know that the most common significant risk factor for developing of an hepatocellular carcinoma is the cirrhosis, and the cause of cirrhosis which has been is an hepatitis B and hepatitis C, followed by alcohol, NASH, and aflatoxin. Irrespective of that as an etiology, the common pathogenesis of development of hepatocellular carcinoma is an chronic liver damage leading to the completely damaged hepatocytes, which ultimately leads to development of an SCC, and if not picked early, can develop into an advanced SCC in the form of an multiple lesions that develop into the liver. As also we know that around 80 to 90% of the liver cancers has been found in cirrhotic patients. And out of this, around 10 to 20% SCC can develop in the patient without cirrhosis, especially in hepatitis B patient and NASH patient. It also in that same WHO report, it has seen that SCC risk factors was very vary by geographical region. As you can see that now SCV is highly associated. SCV is mostly associated in the West and Japan, and hepatitis B is really common causes of an SCC in our East in Southeast region, while alcohol is a key factor in development of SCC in all parts except the West. And slowly now they are finding that NASH is gripping all the countries, and it is now becoming an emerging cause of an hepatocellular carcinoma, especially in the non-cirrhotic patients. Where the India stands in 2020 in the same chart, it is found that in WHO there was around 35,000 new cases of liver cancer detected in 2020, making 10th most common cancer of overall was found in India. The liver cancer is found to be 8th most common cause of liver mortality of all the mortality found among all the cancers, and it has found that nearly 33,000 patients has died because of liver cancer in 2020. There is one observation study which is published from Bangalore Medical College, where they found that incidence of SCC is ranging to about 1.6 per 100 years follow-up, and the incidence rate is definitely found to be much more in men as compared to women. And now they have come to that NAFLD has become the major risk factor for chronic liver disease, cirrhosis, and SCC in India. There was also a very nice observation study which is published in Indian Journal of Gastroenterology in 2017, and they are finding that in the 3-year observation studies, NAFLD has accounting of 51% of patients, followed by hepatitis B and hepatitis C. So there was some changing incidence in the red that now NAFLD is slowly gripping and increasing the risk of an SCC. So this highlights that there is a grave unmet needs for the disease, both management-wise, in diagnosis-wise, and treatment-wise. So as you all know that SCC has been estimated as a 5-year survival rate of only 18%. That's the fact because we are not able to pick that hepatocellular carcinoma in the early patients, where we can give them a curative options in the form of resection to transplant to ablations. So therefore, there was a study also published in Korea and also in Lancet, which was reviewed that early detection of hepatocellular carcinoma is associated with the better outcomes because larger number of patients get subjected to an curative options. So there was, as you all know, that the incidence of an SCC, which was found by the SK Sarin in their part of region in 2017, the annual incidence is gradually rising from ranging from 2 to 6%. As all know, that is found in mostly cirrhotic. So which patient to be went for surveillance? It includes in cirrhotic patients of child A and B. In child C patients, surveillance is usually not recommended because they already go into terminal stage, but especially if the patients are waiting for the liver transplantation, surveillance is most important. And in non-cirrhotic HBV patient, especially high-risk groups, which includes a male patients of more than 40 years, female patient more than 50 years, and the family history of SCC. So that's a very important. But here I really want to raise a point that SCC, we are seeing that NASH is the most common cause of an SCC even in non-cirrhotic patient. And there was one meta-analysis which showed that the odds ratio of developing SCC in a non-cirrhotic patient was significantly higher as compared to the cirrhotic patient. But as current guideline, no society or no either EASL or HEPASL or any other society recommend what are the high risk group we should go for surveillance for NASH. So this is a really unmet needs currently, though we are really coming that NASH is the most common now, slowly accompanying and causing an cirrhosis and causing an SCC in these patients. So we all be very well aware that ultrasonography of an abdomen is regarded as standard surveillance test. But the problem with an drawback of ultrasonography is that the pool sensitivity or detection of ultrasonography early SCC is only 47%. So whether the whether can we really put forward a CT or MRI as a surveillance method? There was an RCT which comparing an 6-monthly UHG versus an triphasic CTA annually, and they found that a biannual ultrasound found to be more sensitive. Biannual ultrasonography found to be much sensitive as compared to CT. So they found that putting a patient for surveillance by CT scan is not so most cost effective, and rather a biannual UHG plus is quite effective in detecting what we want to detect in the form of early SCC. There was also a sensitivity serological surveillance method in the form of alpha fetoprotein. A sensitive alpha fetoprotein detection of 66%, but we really have a drawback of even alpha fetoprotein that like on 20-30% only it is detected, only it is elevated in early SCC. Therefore, it comes in the combination of a radiological method and serological test, where the sensitivity and specificity of when combining has little bit increased to around 70% when compared to the isolated method. And therefore, all the societies, EASL, APASL, and American, surveillance has included into in the form of ultrasonography of liver with serum alpha protein. And the interval what we come and we found in various RCT that it is a 6-monthly interval the patient should subject to this ultrasonography and alpha fetoprotein for detection of an early SCC. A diagnosis has not changed for detection in last decade. More about a triphasic CT or a triphasic MRI, which can detect a typical pattern of an, as seen on the right hand side, like arterial phase, hyperenhanced phase plus portal venous washout. And if this pattern is detected in the background of cirrhotic liver, it is almost 100% specificity of hepatocellular carcinoma. And in the presence of this tissue pattern, in this pattern, there is no tissue diagnosis is required. So nothing has changed in the form of a diagnosis. But yes, one thing has been changed in the form of recently, which has also been enrolled by our Puri recommendations and also by the society, like in triphasic MRI with this hepatobiliary contrast agents in the form of catoxidate, disodium, and diglumine. They have found that if the lesion is less than 1 centimeter and your other tests are equivocal, this type of study can really detect and can diagnose an SCC with a sensitivity or ranging of 78% and specificity of 94%. So this is one thing really, if you found a lesion less than 1 centimeter, this type of study really can helpful for detection of SCC. This another word which has been mentioned is an contrast enhanced ultrasound. Hope the radiologist can give an idea about this, like how really it is helpful or not. In Nagpur, I not find that okay, this contrast enhanced ultrasound is much favorably performed, but it has seen that it is particularly helpful in the patient with a renal failure, and it has found to be even a higher specificity as compared to CT and MRI, especially for the smaller nodules less than 2 centimeter, with a sensitivity as you see 92%. So this contrast enhanced ultrasound is really upcoming and now slowly endorsed by all the hepatological society. If your patient is having some renal failure, some problem that you can't able to subject for a CT or MRI. For better standardization of an reporting, this LIRADS, which is called as the liver imaging reporting and data system. So this is a system which has been that every SCC or every nodule in the cirrhotic liver or even sometimes mostly a non-cirrhotic liver should be reporting by the LIRAD score. It consists of 8 categories, and this LIRADS 5 category has almost 100% specificity for diagnosis of SCC. So mainly it is for standardization of for reporting of an hepatocellular carcinoma and a background of mostly a cirrhotic liver. So this is mostly endorsed by all the society that reporting should be often more about LIRAD scoring system. Must talk about FDG-PET in other tumors. There is no significant role of FDG-PET in diagnosis of hepatocellular carcinoma except for detection of a distant metastasis. So this is something that we should be very careful that for diagnosing, first line therapy is not a PET scan. It is mainly used for detection of mostly metastasis. But there are some transplant physicians or transplant surgeons, definitely they evaluate if the evaluation of SCC in ability to predict SCC recurrence. So if the patient has a more FDG uptake, the chances of recurrence of tumors is much more higher. And may the patient be not subject to the liver transplant and may subject to some form of locotherapy or systemic chemotherapy. Tumor markers and diagnosis. Alpha fetoprotein is a widely studied tumor marker in SCC as compared to other tumor markers of SCC. At a level of more around 500 nanogram per ml, the sensitivity is 50% and specificity reaching to around 90%. But however, only 20% of early tumors has elevation of alpha fetoprotein. So that's the one drawback of alpha fetoprotein. The systemic review of 13 studies has suggested that if the higher the level, that more than 1000 nanogram per ml is associated with the poor outcomes of liver transplant SCC. So that is a very good prognostic marker for the patient of an SCC. Newer biomarkers like PUCA2 in combination alpha fetoprotein has sensitivity and specificity reaching more 90%. But currently, no society is endorsing that only you can diagnose the SCC. If you found a cirrhotic with nodule and we have an alpha fetoprotein PUCA elevated, then you need a diagnosis of, we can't say. But really, Japan, Eastern countries are really coming out very strongly with the PUCA system because they found that this PUCA get elevated more oftenly in the early tumor as compared to alpha fetoprotein. But the standardization still not endorsed by any other societies or any US societies. So still now we are alpha fetoprotein is the tumor marker that we mostly use for diagnosis along with an cross-section imaging. Yes, as I already said, the routine use of biopsy is not at all recommended. Biopsy, as you all know, is associated with an bleeding rates of 3.4%, and the needle track seeding tumor cell is definitely definitely reaching to our 2.7%. But there are some indications where really we want to go for liver biopsy, especially in the patient having an inconclusive findings in the background of cirrhosis, lesions, especially non-cirrhotic liver, where the classical pattern is not able to see, lesion with an vascular liver diseases, when the patient having a mixed elevation of an all the like CA, CA 19.9, and there is not a typical pattern, and the liver lesion without an evidence of an HCC risk factors. So there are indications, but the indications are very few and hardly practice. We require sometimes when the equivocal, the liver biopsy has to be very carefully seen because it carries a risk of bleeding and also an seeding rate or needle seeding track around 2.7%. Staging of hepatocellular carcinoma is very, very important in the form of prognostication and treatment allocation. But problem with the staging system, it is very, very variable, and it depends upon the various factors, including patient factors like a performance status, a tumor factors in the form of tumor burdens, liver factors in the form of liver function, in the form of CTP, MELD score, and some like etiological factors. There are some staging system. Till now, there are more than 20 staging system has been said about hepatocellular carcinoma, starting from Okuda, which is the first staging system in 1985, has evolved so much so that you can see that some tumor staging systems helps in the treatment decision. Some tumor staging system helps in the score-based staging in the form of survival. In the coming few slides, I'm really discuss about the most upcoming and most validated tumor system staging system for hepatocellular carcinoma. As you all saw, the BCLC staging system is widely validated and validated by all the societies of the hepatology. And just I'm going to attention that this BCLC staging system divides the tumor, divides an HCC patients into and more about 4 categories, starting from very early stage to terminal stage. And for very early stage, a lesion which is less than 2 centimeter and having a good function, they advise ablation and resection. So this we should verify, and this is not there is no controversy regarding this that early stage. In very early stage, there is something that a solitary lesion less than 3 centimeter. If the patient is fit for resection, is a resection. If the patient is fit for transplant. If patient is not fit for transplant and resection, ablation is a treatment what they offered for an early stage tumor. And for the multiple stage lesion, definitely a transplant is what they have advocated. The most controversial stage is an intermediate stage B, where they found that patient is only subject to chemoembolization. This was much debated, and currently also debating whether the patient with this intermediate stage B can subject to only a TACE therapy or not. Then there is an advanced stage for only systemic chemotherapy was advised in the form of sorafenib, and there is a terminal stage only life support was advised. So this was a very stage system which has been came in 1993, updated multiple times, and in 1998, in 2018 also updated. Another most common, another system which was much more radically used in transplant center is a Hong Kong staging cancer system. It has been said that Hong Kong staging system, and also been there that it is more radical, it is more discriminatory for the patient selection, and definitely it increases the survival as compared to BCLC stage system. So we can see that it has increased it has allocated more patients into a transplant. It has allocated more patients into a resection categories. We can see even if the patient having a stage C, child C, stage 5, they have offered a liver transplant, which is really not seen in the BCLC staging system. So yes, the studies has come regarding the comparison of the BCLC versus Hong Kong staging system, and it has found that a median overall survival, which is treated by the Hong Kong staging system, was 16 months and compared to just an 8 months by BCLC staging system. But we should also come into the regard that there is no difference in the median survival when compared to the early stage in BCLC. So for an intermediate stage, it has found that Hong Kong staging system has found to a better survival, but for early stage tumor, BCLC and Hong Kong performs the same. So BCLC is a widely accepted staging system, but Hong Kong staging system is more practical in deciding the treatment, especially in early and intermediate stage tumor. This is a very nice study which is performed, which has been done by Tata Hospital in Bombay, where they have given an Indian validation for this Hong Kong staging system, where they study the retrospective study of 144 patients who underwent a resection at HCC. They found out what is the survival analysis was performed out of this 144 in 106 patient, and the median follow-up was 51 months. Just to see a median characteristic for all these patients who are under resection, majority patient were having a child A patient, majority of having an intermediate stage of BCLC, and majority also in Hong Kong stage 2B. So what they have seen that as compared to BCLC and Hong Kong staging system, there is a larger gap difference in the intermediate group. Intermediate group has been found to be a very, very better prognosis in Hong Kong staging system as compared to a BCLC staging system. And what they have come to a conclusion that stage B BCLC staging system represent 90% of surgically resected patient. So what BCLC say stage B should go for chemoemulation. This study and Hong Kong staging system, they say they're resectable. Overall performance status are definitely is good. Perioperative, post-operative morbidity and mortality is also quite acceptable in this patient. So definitely there was a need for refinement of an BCLC staging system, particularly in intermediate stage B patients. So this was the shortcomings of BCLC staging system. One very important, as all we are subjecting, is a performance status. We don't know if a patient goes into higher performance status and we directly go into some type of palliative therapy, but we don't know whether the symptoms are because of cancer or because of cirrhosis. This was not been clearly mentioned in BCLC. There is a quite heterogeneity in the management because there are some data which is very strongly coming that resection is a treatment of choice, or we should for BCLC, but intermediate B, but BCLC endorsing only chemoembolization and survival is 2.5 years. Only TACE recommended as a first line treatment. There was no downstaging, there was no bridging therapy which was mentioned in the BCLC staging system. And liver resection and transplantation is only possible in selected patient of hepatitis in BCLB B patient. That was also one of the very controversial thing. And we all know that there is a frequent deviation of a guideline recommendation in the real world clinical practice. So that's a very much, there is shortcomings of BCLC staging system which you can see. So what did then? The INASL came. The INASL modified the BCLC staging system. So what they have modified, that intermediate stage group, they have just added a TARE or some external beam radiotherapy. They have not added any resection or transplant. What they had another added, they added in terminal stage B patient, if the patient is in Milan's criteria or some extended criteria, they may go for transplant. So only two modification which was done by INASL, but this modification was also not giving any idea regarding downstaging, bridging, EBRT, nothing they had going, just they had added and they found that these are the two modification and still we are going. And then come the main update, which just came in May 2020 of BCLC, where they completely refined an intermediate state of BCLC B. The first line and second line systemic therapy for patient of advanced chemotherapy has advanced from sorafenib to know as well as that like in a program death apoptosis agonist. And they introduced the concept of treatment stage migration and also an untreatable progression. And therefore, the additional indication of transplant was also indicated. So they completely redefined the BCLC and this is what it appears much more complex. So just concentrate on the intermediate stage of hepatitis B, where they are found that with the patient having a transplant criteria in the intermediate group, they should go for a transplant and they have a good survival. If the patient is not fit for transplant, subject patient to the TACE, and if the TACE downstage it, go for a transplant. So that was one thing. And if still the patient is not able to fit in intermediate, then patient should be given to systemic treatment, and systemic treatment is not restricted to sorafenib. It will more talk by Dr. Samir sir, who will telling about a first line chemotherapy of combination drugs and a second line chemotherapy of more about an immunotherapy. So a lot of modification has came. So really, so one thing that what is mean by this treatment state migration, that if a patient is not if the patient is not fit for a particular stage treatment, then he should go to an advanced stage treatment, which is we call as a treatment stage migration. Untreatable progression are the patient who are non-response to the particular step. If the patient is not responding, if the patient is coming intermediate way, we offer a TACE patient. We do a particular 3 cycles of TACE, not responding, patient should give you a combination treatment of TACE plus a systemic chemotherapy. And definitely by this all highlights the personalized treatment decision. None of the patients should be allotted to a particular stage. We just fit that one stage, like one size fits for all. It is definitely not allowed. It is a personalized treatment care. Every patient has to be talked in has to be seen in different ways and offered a more curative options than the more about a chemoembolization or some palliative treatment. Yes, there are few improvements, but some lacunae still persist. Substaging of BCLC, transplant is offered, but again, resection has not been given an option. That's the one drawback of BCLC, what I saw as a lacunae. Performance status of 1-on-T is still considered as an advanced HCC that is contraindicated for hepatic resection. there are much more reports or more studies are coming that performance status is not related to increased morbidity and mortality. Hepatic vein and bile duct invasions are still a blind spot. So if a tumor is resectable and goes into an bile duct, it increases the bilirubin level and increases the child's patient. So what to do about this patient, whether they are a poorer candidates of surgical resection has not been clearly clear. And definitely this EBRT or external beam radiotherapy as a treatment option is not included in the current algorithm. So there's few studies I just want to mention. This was a study which is published in Journal of Journal of Hepatology, where partial hepatectomy versus TACE for resectable multiple hepatocellular carcinoma beyond Milan criteria was subjected. It was a randomized control trial. It's a very good study. So as you can see, and status characteristics, majority of patients having a child A patient, number of tumors you can see 2, 3 more, near about 50% of the patient, and distribution of tumor was more about right more than the left. So what they have found that overall survival of the patient who's underwent hepatectomy was much more better than the patient who's underwent only for this test. So what they have found that 1 year, 2 year, and 3 year overall survival rates was much more better in a hepatectomy group than only a TACE group. So that was one of the really loopholes of an BCLC. Still they're recommending that multinodular, we should go only for transplant. Resection is not at all possible. So here really we should, the surgeons is definitely in the house. We'll definitely throw some idea on it. And again, most important study which is published in JAMA Oncology is an efficacy and safety of an TACE plus EBRT versus sorafenib in hepatocellular carcinoma in microscopic vascular invasion. So this was the study group. You can see majority here also, majority patient having a child A patient, majority of patient having a main portal vein thrombosis, and what they have found that again the progression-free survival at 24 weeks of TACE RT was much more better than only sorafenib. And what they have come that a first-line treatment of TACE plus RT is well tolerated, provided an improved progression-free survival, objective response rate, and time for progression and overall survival as compared to sorafenib treatment. So this was a two problem like partial hepatectomy, and second is EBRT combination has not been approved by BCLC till it. But yes, there are some studies which are really coming up. Again, since we are all gathered together, there was a very nice treatment allocation and MDT management SCC. It has found that a combination of this modality treatment not
Dr.
only
Bhushan.
to the outcome, but
Bhushan.
also allow.
You already exceeded time. Just
Yes,
finish it
last
earlier.
slide, last slide. Thank you. Yes, sir. And also, as you say, and there is a survival benefit of a patient who has managed by MDT as compared to the patient who has been allotted by just versus those who were not allotted for this MDT management. So take home message, in India, there is a scarcity of information on hepatocellular carcinoma. The unpublished data really showing that the incidence of HCC is rising. NAFLD is likely to become the most common etiological factor. For identification of early tumor, it is semi-annual ultrasonography alpha fetoprotein. I not talk about the prevention of SCC, but yes, management of and providing antiviral therapy, universal hepatitis B vaccination for all the newborns, step to control alcohol should be there for decreasing the incidence and the detection of early tumors. Dynamic CT and MRI used for diagnosis. Reporting is preferably done by the LARAT scoring system. Tissue diagnosis of SCC is not at all required for all the patient. There is no significant role of FDG PET except for detection of METs. Newer guidelines are incorporate several improvements on recent SCC treatment, but future refinements are still there regarding the role of surgical resection and EBRT, and treatment which is planned to MDT was associated with a better survival in this patient. Thank you for your attention. These are the various guidelines which has been published for management of hepatocellular carcinoma.
We invite now we invite Dr. Tejas to discuss about loco-regional therapy in HCC.
Good evening, everyone. I'm Dr. Tejas Sadavarte, an interventional radiologist, and My topic for today is loco-regional therapy in HCC. So since Bhushan has already put light on the regarding the diagnosis and the staging system of the HCC, I'll directly jump on to my topic. So the therapies, loco-regional therapies that can be offered in HCC are basically transarterial therapies and ablative therapies. So in transarterial therapies, there is transarterial embolization, bland embolization, chemoembolization, which also includes conventional TACE and drug-eluting beads TACE, radioembolization, and intraarterial chemotherapy or hepatic artery infusion therapy. So, and in ablative therapies, there is radiofrequency ablation, microwave ablation, laser ablation, HIFU, high intensity focused ultrasound, cryoablation. In chemical ablation, we can use percutaneous ethanol injection and acetic acid injections. And in non-chemical, non-thermal ablation, there is irreversible electroporation and light activated drug therapy that can be offered. First, I'll speak on transarterial chemoembolization. Basically, TACE remains the standard therapy for patients with unresectable HCC, that is the intermediate stage. It involves delivery of chemotherapeutic agent precisely into the tumoral arteries and followed by embolization of that artery. So two types of TACE, conventional and DEP TACE, and different chemotherapeutic agents have been used for TACE. So this is the BCLC classification, which clearly shows that the utility of TACE is in the intermediate stage, stage B, and TACE can also be offered in very early and early stage HCC, in which ablation or transplantation or resection is not suitable or not feasible. So this is a case of conventional TACE in which we use lipiodol and a chemotherapeutic agent. So this is the image A shows the pre-procedure CT in arterial phase showing a hyper-enhancing nodule. And this is the image B is the intra-procedure image. And C image is the post-procedure CT scan, which is showing a dense cast of lipiodol. This is another case in which DEP TACE was done. The MRI showing a heterogeneous nodule in right lobe, large heterogeneous nodule. The second image is showing the vascular blush, and the third image is the post-procedure CT scan, which is showing non-enhancing lesion. Another case of DEP TACE, large HCC, showing hyper-enhancing nodule, the abnormal vascular blush, and post-procedure CT showing the blush is not there. So the chemotherapeutic agents used for TACE are doxorubicin, cisplatin, and epirubicin. No drug has been proved to be superior to another. So, and the most common drug used as monotherapy is doxorubicin, and it is followed by epirubicin. And the multi-drug combination consists of doxorubicin and cisplatin and mitomycin. So these are some studies showing the efficacy and safety of conventional TACE versus DEP TACE. So DEP TACE has a higher complete response rate and a higher overall survival rate in patients with HCC. Another study showing comparison between the DEP TACE and the conventional TACE. The 1, 2, and 3-year overall survival rates and the relapse-free survival rates were significantly higher in DEP TACE group. So some advances in the hardware and the techniques in TACE are the balloon occluded TACE, cone beam therapy, computed cone beam CT used during the TACE therapy, and combination treatments in which TACE along with ablation and TACE along with the tyrosine kinase inhibitors can be offered. So this is a case of balloon occluded TACE CT showing the image showing here is a balloon placed in the feeder artery, which offers better penetration of the chemotherapeutic drug. Other indications of TACE are the preoperative TACE and bridging TACE for patients awaiting transplant. These are some studies showing efficacy and safety of preoperative TACE for HCC. The combined therapy was associated with a higher overall survival for patients with HCC in BCLC stage B tumor. Another study showing long-term survival and post-operative complications of pre-liver transplantation TACE in HCC. So the patients treated with TACE had similar survival and post-operative outcomes to non-TACE patients. However, they had worse prognostic features compared to non-TACE patients. And these findings strongly support the current European and the US practice guidelines that neoadjuvant TACE can be offered for patients with longer expected waiting list times, that is specifically to be more than 6 months. As I've already mentioned, the ablation therapies. So the heat generating therapies include radiofrequency ablation, microwave, laser, and HIFU. And in cryoablation, heat is not generated. Basically, it is a hypothermic therapy. So for ablation to be offered as the first line treatment, it is offered in HCC. Which are in very early stage and the early stage, that is stage 0 and the stage A lesions, in which if the patient is not a potential candidate for liver transplantation, and in early stage HCC, in which if it is a single lesion or less than 3 nodules, which are less than 3 centimeter, and patient is contraindicated for liver transplant. In such cases, ablation can be offered. So early stage HCC, role of ablation, solitary HCC less than 3 centimeter with or without portal hypertension, ablation is preferred. And if the site for ablation is high risk, then resection is preferred. And multifocal HCC within Milan criteria, that is up to 3 HCC nodules, each less than 3 centimeter, then ablation is offered. RFA, radiofrequency ablation. The overall 5-year survival rate is around 40 to 68%. And the local tumor progression ranges from 2.4 to 27%. Morbidity and mortality, 0.9 to 7.9% morbidity and 0 to 1.5% mortality post-treatment. And the predictors for poor overall survival are the childhood class B, elevated serum AFP, and presence of photosystemic collaterals. The overall survival is not significantly different between RFA and surgical resection. Recurrence-free survival is definitely better in resection. However, major complications and hospital stay are more in resection, and most recurrences can be treated curatively by iterative RFA, but not by repeated surgical resection. And obviously, the treatment cost related to the hospital stay, it is more in resection versus ablation. And contrast enhanced ultrasound and multimodality fusion imaging would improve outcomes in ablation. According to the EASL 2018 guidelines, thermal ablation with RFA is the standard of care for patients with BCLC 0 and A tumors, which are not suitable for surgery. And in patients with very early stage, that is BCLC 0, RFA in favorable locations can be adopted as first line therapy, even in surgical patients. Another local ablative therapy is the microwave ablation. That is also a safe and effective modality. It is an alternative option to RFA. When you compare RFA and microwave ablation, the area covered is more predictable in RFA. I'll come to that. So in RFA, the area covered is slightly unpredictable due to tissue charring and boiling, which can cause increase in impedance that reduce electrical and thermal conductivity. And in microwave ablation, there is rapid and homogeneous heating. And also in RFA, the procedural time is slightly more, and the ablation volume is less as compared to the microwave ablation. So when you compare RFA and microwave ablation, it is slightly preferred. Microwave ablation achieves more extensive tumor necrosis than RFA and is potentially the best option for those patients with early HCC less than 4 centimeters in size. So it potentially provides better tumoral response, higher temperatures in a shorter period of time, leading to excellent local tumor control and less concerns of heat sink. So this is a case in which microwave ablation was done, a 52-year female, HCC in right lobe, and AFP was elevated, but the patient was not, the size was around 4.5 centimeters and a single lesion, and patient was not willing for surgery. So we offered her a microwave option of microwave ablation. This is a pre-procedure CT scan showing a tumor in right lobe. And this is the second image showing antenna of microwave ablation. The procedure was done ultrasound guided. We can see the needle going across the liver parenchyma into the lesion. And this is the CT scan was done immediately post procedure, which shows the ablated lesion. And the second image is a comparison between the pre and the post. The pre image is showing hypervascularity, whereas the post image is not showing any vascularity. And follow-up scan was also done, which shows decrease in the size of the lesion. And obviously, there is no enhancement. So if the patient is willing for transplant, and in such cases, does ablation need to be done? So upon enlisting the patient for liver transplant, treatment of HCC can be done if the expected waiting time for transplant exceeds 6 months, and the treatment offered can be ablation, TACE, or TARE. So here we come to the comparative studies between ablation and the resection. RFA versus hepatic resection for small HCCs. So hepatic resection overall has a better overall survival and better recurrence-free survival. However, it has significantly higher incidence of treatment-related complications, and as I already said, the longer hospitalization duration. So here are some studies which are showing in resection group, the overall survival and disease-free survival was better. However, the complication rate was also more in the resection group as compared to the ablation group. This is a study, a multi-center randomized controlled trial to evaluate the efficacy of surgery versus RFA for small HCCs, SURF trial. So in this trial also, it revealed that the overall survival and the recurrence-free survival were not significantly different between patients undergoing surgery and RFA for small HCCs. Now we come to the combination of transarterial and the ablation therapy. Both of these therapies are widely used techniques and have their advantages, also some disadvantages or corresponding deficiencies. So in TACE alone, the necrosis rate is low, and the intrahepatic recurrence chances of intrahepatic recurrences are there. And in ablation, it is not considered much effective for nodules which are larger than 4 centimeter. And there is also risk of incomplete ablation and local recurrence. So to negate both the deficiencies in both the groups, the combination therapy can achieve better outcome. The rationale for combination therapy is TACE causes vessel occlusion and reduced tumor perfusion. It reduces the tumor volume, causes heat sink effect, and results in larger ablation zones. And TACE can identify satellite lesions which can be included in the ablative zone. And ablation causes hyperemia in the parenchyma, which will eventually cause preferential flow and high uptake of chemoembolic drugs in the tissue surrounding the ablation. And residual tumor cells or satellite lesions are targeted. Here is a study in which individual or combined TACE and radio frequency ablation for hepatocellular carcinoma. Meta-analysis showing individual or combined TACE and RFA studies. This included 21 studies and included more than 3,000 patients. So the conclusion was TACE combined with RFA was more effective in HCC than TACE alone. Another study, which is also a meta-analysis, combined RFA or microwave ablation with TACE, which can increase the efficiency in intermediate stage hepatocellular carcinoma without more complications. This study also concluded that TACE combined with RFA or microwave can provide significantly better overall survival, progression-free survival, and local tumor control than TACE monotherapy for patients in intermediate HCC. I'll just run through the studies because they are very similar conclusions. So we come to a point where we have to offer a combination therapy, but ablation and then TACE, or TACE and then ablation. So in our practice, usually we first offer TACE because that gives us a marker for ablation while doing the procedure. So here is a study, thermal ablation combined with transarterial chemoembolization for HCC. What is the right treatment sequence? there were no differences found with respect to overall survival between the two treatment sequences. And TACE was performed after thermal ablation with an average interval of 3.5 days, whereas thermal ablation was performed after TACE with an average interval of 30 days. Now I come to another treatment modality that we can offer in the loco-regional therapy, that is radioembolization, or also called as yttrium-90 radiotherapy. So it is a delivery of radioactive yttrium-90 labeled microspheres via catheter directly at the disease site or to the feeding hepatic artery. So these are microspheres. They emit beta emissions, and which are capable of delivering lethal radiation doses to neoplastic tissue, and while sparing the more distal or while sparing the surrounding normal tissue. And why yttrium-90? Because it is a beta emitter and the penetration depth is very low, that is 2.5 mm. So it spares the surrounding normal tissue, and the maximum depth that it can penetrate is 11 mm. So liver-directed external radiation therapies are limited in scope. That is because the radiation tolerance of normal hepatocytes is less than the neoplastic tissue. So the maximum tolerated doses of external beam radiation therapy is 30 to 40 grays. And whereas with yttrium-90 microspheres TARE, the total liver radiation doses can be increased up to 80 grays, which are very well tolerated and with no adjacent hepatic damage. And it is approved by the FDA. So this is the difference between the external beam radiotherapy and the selective internal beam radiotherapy. So which gives a concentrated dose at the site of interest. So the indication for TARE is the stage 0 and stage A, as well as per the newer guidelines, stage B, intermediate stage lesions. And these are the ESMO guidelines released in 2018, which also include intermediate stage B lesions for selective internal radiation therapy. So according to the Sanarobi et al., integrating radioembolization into the treatment paradigm for HCC. So HCC, which is confined to the liver, and if the patient is suitable for liver transplantation, TARE can be offered as a bridging treatment. And if the patient is not suitable for liver transplantation, child PUG A and B, and not suitable for resection and ablation as well, then TARE can be offered to such patients. Two types of commercial products for yttrium-90 are available. The SIR spheres, which are indicated for unresectable metastatic liver tumors and from primary colorectal cancer, and TheraSphere, which are indicated for unresectable HCC. So this is a TARE setup. There's a acrylic case which blocks the radiation. This is a study showing the pre-CT, showing a lesion around 5 by 5 centimeters, approximately 5 by 5 centimeters. The SPECT scan was done. The planning for radioembolization requires a SPECT scan after injection of macroaggregated albumin, and which determines the lung shunting of the material into the lung. And if it is more than 20%, then the treatment of TARE cannot be offered. And so this is the intratherapy scanning SPECT CT with yttrium-90. And this is a post-CT, post-procedure CT, which shows reduction in the size and reduction in the enhancement pattern also. And this is a post-procedure SPECT CT, decrease in the size and the uptake of the agent. So the potential role of Y90 in HCC, in early stages, it can be offered as a segmentectomy, which can be an alternative to ablation, and radiation lobectomy, which can be a bridge to resection in intermediate stage. If the lesion is large, unresectable, then it can be offered. The TARE procedure can be offered. And in advanced stage with portal vein tumor thrombus in patients of child A to and child PUG B7 categories. So the concept of radiation segmentectomy is
20 minutes
administration of TheraSphere.
20 minutes.
Yeah. Administration of Y90 to less than 2 hepatic segments through a catheter placed in segmental arteries, which results in selective delivery of high dose radiation and minimizes exposure to normal hepatic parenchyma. So the overall the median overall survival was 6.7 years, and the median time to progression was 2.4 years, which was more than other treatment modalities. So the benefits are high rates of complete pathologic necrosis, minimally embolic, and selective infusion to minimize the damage to liver parenchyma, and treatment option for patients with low tumor burden who is not an ablation or surgical candidate. Radiation lobectomy, it was first described by Jacobs et al. In 2008. This offers a pathway to curative intent therapy such as resection by causing atrophy of the treated lobe. So the volumetric effect, which can range from 21 to 57% relative hypertrophy of the contralateral lobe. And it can be seen as early as 1 month post-treatment with maximal response at 9 months. So again, lobectomy is a safe and effective technique to cause hypertrophy and tumor control during hypertrophy before resection. Radiation lobectomy can also be offered as a bridge to resection. TARE induced frequent and similar increases in functional liver remnant volume compared to portal vein embolization. So in this study, the number of patients was 34 and the response rate was 63%. Median overall survival was 13.5 months, and mean maximal increase in contralateral liver volume was 42%. And median ratio of contralateral to total functional liver volume increased from 48.5 to 64.9%. Another study, the number of patients were 24 and the mean administered dose was 1.75 grays. And the median increase in volume of left lobe of liver was 34%, and that of right lobe was 11%. So TARE in intermediate stage HCC, overall response rate was 75%. And disease control rate is significantly higher than TACE. In TARE, it is 93% versus 71% in TACE. And this study, which showed intermediate stage hepatocellular carcinoma, comparison between radioembolization and chemoembolization. So the mean tumor size in this study was in the TACE group 5.9 centimeters, and in TARE group it was 8.2 centimeters. And the mean hospitalization time was in TACE group it was 5, whereas in TARE group it was only 1 day. And the median overall survival was 18 months in TACE group and 16.5. However, the median time to progression was significantly higher in the TARE group. Another study, yttrium-90 radioembolization, which significantly prolongs the time to progression. It is all similar studies which are saying that in TARE, the median overall survival and the time to progression is slightly more than the other treatment modalities. Another utility of TARE is in HCC with portal vein tumor thrombus. So the ablative transarterial radioembolization is intended to selectively deliver high dose radiation only to the hepatic segment. So this promotes the maximum cytotoxic effect within the targeted area with delivery of enough radioactivity to kill the tumor. And patients with portal vein tumor thrombus in main portal vein and or its left and right branches were included. So the patients treated received a higher median activity with resin microspheres and a higher median dose with glass microspheres. So again, same, they offer longer median overall survival and longer post-treatment survival. This is another study, yttrium-90 glass sphere radioembolization, which serves as a
Hello.
safe and effective.
I think we are exceeding the
Yes.
time, and more or less same thing is being
Yeah.
repeated, please.
So again, TARE can be offered for downstaging for liver transplantation, and also another treatment modality, that is hepatic arterial infusion, in which a combination of oxaliplatin, fluorouracil, and leucovorin is infused through a catheter into the hepatic artery for over 24 hours. And it has the overall survival is more than the TACE group, The response rate is also more than the TACE group, and the progression-free survival is more, and the incidence of adverse events is less than the TACE group. However, it requires placement of a catheter into the super selective placement of catheter into the feeding hepatic artery for over 24 hours. So the conclusion, TACE remains the mainstay of intermediate stage HCC. Evidence suggests mild superiority of DAPE TACE over conventional TACE, and combination therapy showed better local tumor control and overall survival. And there are increasing evidence to suggest better tumor response with the use of cone beam CT and combination therapy while doing the procedure. And when combining TACE with ablation for HCCs more than 5 centimeter, TACE may be combined with microwave ablation. And preoperative bridging TACE may be associated with better outcome. And TARE is a promising and an increasingly popular treatment option for palliative care of patients with metastatic liver disease and unresectable HCC, which showing decreased tumor volume and increased to progression. So HCC, it is a multidisciplinary or multi-specialty teamwork, which includes gastroenterologist, hepatologist, hepatic surgeon, radiation and medical oncologist, and interventional radiologist. Thank you.
Thank you, Dr. Tejas. It was indeed a nice and an exhaustive presentation. Now I invite Dr. Ravi Mohanka on stage. Dr. Ravi Mohanka is a senior consultant and a director of HN Reliance Hospital's liver transplant unit, and he belongs to Nagpur. Sir, welcome.
Thank you. So we'll just, thanks for such a nice background that you've laid for my discussion. So there's only one loco-regional therapy that was missing from the discussion so far, which is external beam radiation. And it is really important because that's why I'll cover that briefly. But other than that, it will be a quick and a brief discussion. So what we are discussing here is there is a patient with cirrhosis and has got HCC. Now, all these treatments that we have heard, TACE, ablation, TARE, even resection, all these treatments will only buy you time. As long as there is cirrhosis, the tumor is going to come back. Even with a curative, so-called curative treatment such as resection, the 5-year recurrence is 90%. With all others, it's much more. There will be recurrence within 2 years or 1 year. But even with resection, it's going to be 90% at 5 years. So the point is, if you have a cirrhosis with HCC, you have to think about transplant if possible. If transplant is not possible, then we have plenty of options, but they will all give you short-term benefit. So now when there is a patient with cirrhosis and has got HCC, their survival is 20%. We heard that. They only 10% are going to be eligible for resection. So now what do you do with this rest of 90% patients? So there are certain criteria, and those are size criteria. So a tumor, in the past, we used to think, what's better than transplant? You have a large tumor, remove the entire liver, you get R0 resection. But we found that there is too much of recurrence. And therefore, we realized that as long as tumor is up to 6.5 centimeters, and if you do a transplant, the recurrence risk is less than 10%. Anything more than 6.5 centimeter, you get a high chance of recurrence. So those are the UCSF criteria, University of California, San Francisco criteria. So if there is a patient whose tumor is within that criteria, then you do a transplant. If somebody's tumor is beyond that criteria, you don't do a transplant because the risk of recurrence is high. But while the transplants are of two types, we know that either cadaveric transplant, DDLT, or living donor transplant, LDLT. Supposing there is a family member who can donate liver for you, then the best thing, if you have a tumor which is within UCSF criteria, do the transplant straight away, don't do any other therapies. But if you don't have a person to donate, then what do? You put that patient's name on the waiting list for a cadaveric transplant. Now this period, 6 months to 1 year, is the time of uncertainty, because during that time, the tumor can increase in size. And therefore, a tumor which was curable by transplant will become incurable. So therefore, you have to do something to keep the tumor under control. This is bridging. So if you don't do anything for such a patient, then about 15 to 30% of these patients will drop out, which means during the waiting time, their tumor will progress and they will not be able to undergo the transplant. But if you do bridging, then that dropout rate decreases to 10 to 20%. So in this period, while you are waiting for a transplant, you can do TARE, you can do TACE, you can do RFA, and we can do several other things also. And all these armamentarium of things that we discussed already, these are available for us. If somebody has a beyond UCSF criteria tumor, then of course we can't go for transplant straight away because the risk of recurrence is very high, about 40% plus. So therefore you do what is called as downstaging, which means that you do all these therapies with a goal of reducing the size of the tumor so that it fits the criteria. Once it fits the criteria, then the results of such a transplant is the same as if the patient originally met the criteria. So therefore, there is bridging for patients who originally met the UCSF criteria to try to go towards transplant. And for patients who had beyond UCSF criteria, try to do downstaging, and then still the goal is to undergo transplant. Now, what are the goals of bridging? To not only maintain the patients eligible on the waiting list, to maintain them, but also we found that patients who have bridging while they're waiting, they have better, less recurrence after the transplant also. So that's a good goal to have. And then there's downstaging. So we convert a ineligible patient to eligible one. These are the armamentarium that we talked about, except for resection and external beam radiation, which we'll talk about now. I have to give you a little perspective about these therapies. So, you know, the ethanol injection is for all practical purposes gone. The radio frequency ablation and microwave ablation are the most commonly used ones. The TACE, as we heard, there are different types. So these are still within the affordability of an average patient in India. It will cost you about 2 lakhs to 3 lakhs rupees, still possible for somebody to afford. TARE is something that costs about 15 lakhs. So it's really expensive. It's better than TACE in terms of efficacy, in terms of durability of response, but it is really expensive. And therefore you can't really, most patients can't really have it. And even it's not available in a city like Nagpur, let alone smaller cities. So it's going to be really tough to have TARE. Resection, again, we'll talk about that. If you look at the results of TARE and external beam radiation, they are both radiations. One is given from inside through beads and one is given from outside. But because radiotherapy is so commonly available in India, everywhere, with the same efficacy, the same effect can be had for about 1/10 of the cost. So therefore, now SBRT or external beam radiation is coming up in a big way, especially like in countries like India, Africa, and other countries, because it makes sense for a country like ours. And then there is good immunotherapy and chemotherapy. Unfortunately, chemotherapy doesn't really work, but immunotherapy works in this cancer. Now, there are several questions that are unanswered. Do you do these therapies alone, or do you do them in combination? If you do them in combination, which sequence, like was discussed by Dr. Tejas? And then how do you assess them? How often do you do a CT scan? Do you do an MRI? Do you do an AFP? If you do it, how often do you do it? Do you do it after 1 month of therapy or 3 months after therapy? These are questions which are unanswered, and for all practical purposes, based on personal preferences of people. Now, this is a slide which is from a study, which is a really small study, but it conveys a very important piece of information, which is, whenever we look at any of these therapies and the outcomes of these therapies, there are two things that we need to look at. One is radiological response, which is by the standard RECIST criteria used in all malignancies. And there is complete response, partial response, and all that. And there is pathological response. So only when a patient who has undergone one of these therapies, they undergo a transplant, you have the entire liver available for pathological assessment. And that is when you know in how many % patients you've got complete pathological response, which means there is no tumor. And only patients with complete pathological response, the last column, the 100% pathological response, are the only ones who have lesser chance of recurrence. All others, even if they have, so patients who have complete radiological response, CR, which means there is on the next imaging 1 month after the therapy, you find no viable tumor on radiology. 70% of them have pathological disease on explant, 70% of them. And so that doesn't matter. Whether or not you had radiological response doesn't matter, even if it is complete radiological response, because 70% have pathological disease when you explant the liver. And therefore, only when you have complete pathological response, those are the patients and those are the therapies that are benefiting your patient. All other therapies are only buying you time. Now, the only local regional therapy that we didn't talk about is external beam radiation. And therefore, this is like a standard therapy that all of us are familiar with. Now, obviously, there are potential side effects, but because of its cost and because of its efficacy similar to TARE, I think this is one of the things that we should as a country focus on and put it in our guidelines, the Indian guidelines. Now, the resection as a modality for either downstaging or bridging is an excellent modality. However, like we heard Dr. Bhushan, 90% of patients have HCC patients have liver cirrhosis. So therefore, they have portal hypertension. The moment you do a liver resection on them, they have almost 30 to 40% of risk of decompensation. So they will not die of the disease, they will die of the treatment. So we can't subject a patient to a treatment which will kill them. So therefore, resection is not often feasible. Only in about 10% of patients, resection is feasible as a primary treatment, bridging or downstaging. So therefore, when it is feasible, of course, we should do it, but it is often not feasible. And whenever we do a resection, it's best to do an anatomical resection because of the the vascular supply such that it can reduce the risk of recurrence. But almost most patients will not be suitable for that. There are several studies, and once you have done a resection and the patient gets a recurrence, if you then end up doing a transplant, it's called a salvage transplant, which is not a very uncommon thing. Almost 10% of patients in the West undergo a salvage transplant, but the results of salvage transplant actually are excellent. It's very similar to, not as good as primary transplant, but much better than any other therapies that we are talking about here. We are talking about most therapies with 1 year survival of 60% or 3 year survival of 40%. Here we are talking about 70, 80%, 5 year survival. So there is no comparison. And then discussed by the earlier speaker, so there are several things that are available to assess the response, the several tumor markers, but only AFP is what is commonly used, and others are for all practical purposes been in literature for a long time, but generally theoretical. As far as combined treatments are concerned, again, TACE followed by radiation is better. Obviously, when you combine two treatments, sometimes some of them are better, so that's better. TACE followed by radiation, as external radiation, is also better. And TACE plus radiation, almost 90% patients have complete necrosis. So basically, you're combining the benefit of chemotherapy, ischemia, and radiation, all three. And therefore, they work the best. RFA again improves the survival, and you've heard all this. But the only other thing I would like to point out is the last two, the SPACE trial and the STORM trial. Here, what they've done is they have combined a systemic chemotherapy with one of the loco-regional therapies. At that time, when these trials were being done, there was only sorafenib. Now we have many more options. But then this is the future. This is where we are going to head, because there is systemic disease that we need to take care of, and we need to take care of the local disease. Now, these are some of the studies about how do you bridge a patient. Supposing there is a patient who is meeting criteria and is waiting for a transplant, how do you bridge them? And there are several studies, each using different modalities, but you will notice that their 5 year survivals are up into the 70 to 90% range, depending on what modality you use. Now here, again, the goal is to reach a transplant. The goal is not to continue this therapy as a destination therapy, because if that's the goal, then ultimately at some point you're going to fail. So basically, after looking at all this, we figured out which are the best patients to bridge, and patients who have size of tumor more than 3 centimeters, multiple tumors, waiting time more than 6 months, AFP more than 300, 200, and poor response to bridging are the ones, sorry, not the last one. So these are the 4 criteria are the ones who do best with bridging. And that's why there are some eligibility criteria. Those are the patients who should be bridged for sure. If somebody's waiting time is expected to be 2 months, you may not really need it. But if somebody's waiting time is going to be more than 6 months, they will benefit from a bridging therapy. Similarly, downstaging, initially, when we started doing downstaging, we got only 20% success. So then we realized that, if you restrict downstaging to patients with within certain criteria, then the success of downstaging was up to 60%. And those are the 2 criteria. One is the UCSF criteria. This is different from the UCSF criteria for transplant. These are UCSF bridging criteria. Similarly, there is an Italian bridging criteria. And as long as you bridge patients or downstage patients only within these criteria, you get almost 60% success for downstaging. So if you take tumors which are small, I mean, sorry, you can't read it, but if you take tumors that are small, essentially what this slide is saying is that if you take tumors that are small, up to 2 centimeters or up to 5 centimeters, you get excellent survival. The last one is the ones who did not undergo downstaging, the black line. Everybody else underwent downstaging, and irrespective of what stage it was, they all benefited. But when the moment you reach T3, which means tumors more than 5 centimeters, the benefit goes away. So therefore, you have to select your patients well, and the maximum benefit is patients who have smaller tumors. So multiple studies, and they all use different modalities for downstaging. And again, you will notice that the overall survival is about 60 to 70%. And that RR is relative risk. So that's not what we are saying, but the success rate of downstaging goes from 60 to 80%, and the overall survival from about 70%. Now, the last and the most controversial and new upcoming thing is the systemic therapy that is going to be discussed by our next speaker. But there are only few case reports in this world. So about 30 cases reported that have used systemic therapy as bridging or for downstaging. Now, there are 3 main drugs. So we started off with sorafenib. Unfortunately, it had a lot of side effects. So we started using a brother of sorafenib called as lenvatinib, which is better tolerated. So patients are able to have it. That works well. The second group of medicine we used was nivolumab, which also works well. All are immunotherapy. And now we have a new combination, Avastin plus this, which also works well. So all these studies which were used for bridging, most of them have used nivolumab. Although if you were to do the same study today, you probably will have much better response than these studies also, because we have better drugs available now. So these studies are yet to be done actually, So in summary, bridging is a successful modality, reduces the dropout rates from over 15 to 30% to 10 to 20% per year. So in the next 5 years, all these patients are going to have a recurrence. Downstaging is successful in about 20 to 60% patients, depending on what your selection criteria is. Unfortunately, most of these patients who are childs B or C, they are neither eligible for resection nor for any of these therapies. And those are the patients where we really struggle. Then the choice of modality depends on several factors like the tumor size, location, proximity to the surface, meaning whether it's exophytic or intrahepatic, proximity to vessels, bile ducts, availability, cost. All these are heavily weighing your choice of which modality you choose. And then mostly it's like personal preference. Thank you very much for your attention.
Thank you, Ravi sir. It was an excellent and a nice presentation.
Survival donor.
And the recipient,
Yes,
will they live normally in size?
correct. So
My second question is,
yes.
the majority of the financial institutions of India, including the LIC, are not giving them the opportunity to handle the cases. I am putting this case into the Honorable High Court, and definitely I think we will win it. What is the rate of percentage and the condition of the patient, of the recipient and the donor?
Should I answer this question now or later?
Yes.
Okay, fine. So quickly. So as far as the donor is concerned, they have a risk of about 0.3%. They live a normal life after that. Throughout life. 0.3% donor. 0.3% is the risk to donor. If they don't have that problem perioperatively, they'll live a totally normal life, well proven with a lot of literature. No confusion.
Live total normal life.
Totally normal life. That's right. Recipient, they have about 10 to 15% risk perioperatively, depends on how sick they are. And but they just have to survive the operation in the perioperative period. Once they survive that period, then they will not die of liver failure for the rest of their lives, except if they stop their medication. So their risk is about 10 to 15% perioperative. The long-term risk of chronic rejection, which is about less than 1%. So for liver transplant, unlike kidney transplant, heart transplant, and other transplants, they will have about 10 to 15% depending on how sick they are. But all this risk is perioperative, not long-term. So last question, does insurance cover transplant? It does cover. Unfortunately, what happened 10 years ago, most people used to buy insurance for 5 lakhs rupees. And at that time, transplant was an exclusion. 5 years ago, robotic surgery was an exclusion. But today, if you go to buy any insurance, health insurance, both will be inclusions, not exclusions in your insurance policy. So if you have bought an insurance 10 years ago, then please don't just keep renewing it. If you have to change your insurance to include these two things that have changed in medicine. Only then transplant will be covered. In the past, even when insurance companies used to cover transplant, they would exclude donor costs from that. Now, not only recipient, but even donor cost is covered by the recipient's insurance.
The problem of the recipient after this.
I think,
Doctor.
excuse me. Hello. Hello. I think we can take this question in our dinner session. Yeah. Thanks, Dr. Ravi, for this excellent lecture. And once upon, I will congratulate you for finishing before the time. I think it was 4 minutes saving. So currently we are 10:30. We have 2 lectures left. So I request my next speaker to stick to the time. And we have, just to the information, we have 62 participants which has online connected. And the next lecture is on systemic therapy by Dr. Shrirangwar. He is a medical oncologist at NCI. The topic is systemic therapy, past, present, and future. Samir, please.
So now coming to the last topic, I think we are so late. So I will try to keep you all awake and not to bore you. And I will try to be short and crisp here. So we have already seen this management of SCC required multidisciplinary tumor board, and we need a multiple specialty to be working in collaboration with a good communication between each of them to give up optimum treatment to our SCC patient. So we have seen the role of surgery, means ablation, TACE, TARE, SBRT. So definitely the management of SCC is very complex. It's not that easy. So one of the difficult diseases to treat, I will say. And for this decision making, we need to have communication between the different specialties. But my job is here very easy. It is just to discuss the role of systemic therapy where no one else come in. So it is only one person show here. So I will try to discuss that. So we have already seen in previous lecture how BCLC cancer staging is there and how we decide our treatment based on the stage. So I will discuss here the treatment of stage BCLC stage C, that is the role of systemic therapy here. So this is a very important slide. So this is a slide which shows how the timeline, how the various therapies has been developed in SCC. So if you see before 2007, there was no approved therapy for SCC. There was nothing. Multiple trials have been done already with chemotherapy like platinums, taxanes, anthracyclines, even hormone therapy, even immunotherapy with interferon was tried before this, but all this failed and there was no effective therapy. And the breakthrough came in 2007 with sorafenib. And after that, almost there was nothing for 10 years. 10 years, it was only sorafenib. But again, the picture is changing for the last 5 years. That is 2017. We have now multiple options available for first line and not only in first line, also in second line. So SC is one of the diseases like RCC where there is no chemotherapy, only targeted therapy and now immunotherapy. And this shows how difficult this disease is to treat, because if you see the list of trials, phase 3 trials, most of the trials are negative and only few trials are positive. So for first line, there are 3 positive trials. For second line, there are 3 more positive trials. So I will discuss only mainly first line, the 3 positive trials which we have today and that we use in our routine practice. So coming to the sorafenib, which was the first FDA approved drug for HCC, and this drug was approved on the basis of results of SHARP trial. And this was published in 2000, way back 2007-6. It was published in NEGM. So if you see, this was a randomized double-blind phase 3 trial. And here the sorafenib was compared with placebo. So there was no standard of care that time. So it was compared with placebo in a patient with advanced SCC and only Child-Pugh A, included only patient with Child-Pugh A. So across the various systemic therapy trials, you will see they will take only Child-Pugh A patients. So reason behind that, because if you take more the advanced disease for the systemic therapy, they are more likely to die because of cirrhosis rather than the disease. So that makes the trial biased, and that's why they try to take only Child-Pugh A patients. So if you see the results of this trial, overall survival was significantly better with sorafenib as compared to the placebo. Definitely the efficacy is very dismal. If you see other therapies like surgery or TACE or something like that, loco-regional therapy, but systemic therapy, it is the picture is this only. You hardly get a 3-month OS benefit, and there is some benefit in the time to radiological progression. But that was the only study, that was the only drug which was available from 2006 to 2017. Yeah. So now coming to the next drug, that is lenvatinib. as already mentioned, this drug. So lenvatinib is similar to the sorafenib. It is a multi-targeted tyrosine kinase inhibitor. So this small molecular tyrosine kinase inhibitor acts on multiple receptors on the tumor cells. So lenvatinib acts on receptors like VEGF, PDGFR, FGFR, RET, KIT. So multiple receptors that inhibit. So why this trial was needed? Basically, sorafenib was giving some efficacy, but it was very toxic drug. Hardly any patient was able to tolerate the full dose of 400 mg BD. And there was already patient was symptomatic because of disease, and they used to become more symptomatic because of side effects. So we needed a drug which should be less toxic and more effective, or maybe similarly effective. So this trial was done with lenvatinib, and it is compared now with sorafenib. And this was a non-inferior study. It was not a superiority study, but it was a non-inferiority study. And it has included similar group of patients. And if you see the results of this trial, I don't have anything, pointer is not there. But if you see the overall survival, it was similar between the lenvatinib and sorafenib. That is around 13.6 months versus sorafenib 12.3 months with a hazard ratio of 0.92. And it has proved the non-inferiorities. That means lenvatinib is not inferior to sorafenib. But there are important points which we can see here. Secondary endpoint, that is PFS. It was better with lenvatinib. That is 7.4 months versus 3.7 months. Time to progression was also better with lenvatinib. That is 8.9 months versus 3.7 months. And now the row, overall response rate, 24% versus 9%. So here the sir was saying about systemic therapy as a bridging, where you need downstaging. So this is the drug which can give you some downstaging. So sorafenib will not give you any downstaging. It is hardly 10% response. But here lenvatinib gives you a 24% response. So more chances of downstaging with lenvatinib. So definitely lenvatinib was better in terms of PFS, time to progression, overall response rate. It was non-inferior in terms of overall survival. And most important point, it was well tolerated drug. The side effects are much less. And in even routine practice, when we are using this drug routinely, we see patients getting symptomatic benefit. Their quality of life is getting better. So which is very important in palliative setting. So that's why now this is one of the standard of care for us. So now coming to the most awaited topic, that is immunotherapy. So the most important trial which I will discuss here is IMbrave 150 study. It is a phase 3 randomized study which has compared again the sorafenib with our experimental arm, that is atezolizumab and bevacizumab. So this trial included the same group of patients, that is advanced metastatic unresectable HCC with no prior systemic therapy. This was a very good trial, almost included 501 patients, and they were equally randomized into 2 arms, and the treatment was continued until the disease progression or unacceptable side effects. The primary endpoints were here PFS and OS, and the secondary endpoints were overall response rate. So now, why to combine atezolizumab with bevacizumab? Why single drug cannot be given? So you have to understand basic biology of the disease here. So there are various studies which have shown there are the HCC. In oncology we say immunologically cold tumor and the hot tumor. So immunologically cold tumor means there are no infiltrating T lymphocytes only in the tumor. So whatever you do, they are not going to stimulate the immunity, and their immunotherapy is not going to work in that. But there are some tumors which are immunologically hot. Immunologically hot means so if you see the immune cycle, the first step in the immune cycle is release of cancer cell antigen from the tumor. See, this antigen is recognized by the antigen presenting cell, that is dendritic cells. These dendritic cells then go to the lymph node and they activate the T cells for that particular antigen. And then this activated T cell goes again to the tumor and they try to recognize this antigen which is presenting on the tumor cells, and they try to kill the cell. So this is the immune cycle. So if there is no release of the antigen from the tumor, if there are no antigen presenting dendritic cells are present, and if you give immunotherapy, so it is not going to work because there are no T cells in the tumor only. So if you see there has been report with SCC, some patients having spontaneous segregation because of immunity. And there has been studies which have shown that tumor infiltrating lymphocyte is found in more than 50% of the RCC patient, and these patients have better PFS. So that means immunity is acting, our own immunity is acting against the SCC, but somehow the tumor is developing mechanisms by which they are escaping this immune activity, and this is we call it as a immune escape. So that's why there are a few studies of single agent like monotherapy with Pembro, Nivo, multiple immunotherapy drugs has been tried, you will see response rate. There has been 15% response rate, 20% response rate with single agent immunotherapy, but none of the trials have shown OS benefit. So that's why there was a unmet need to combine two drugs with a synergistic activity to have a better efficacy. So why the bevacizumab was selected here? So bevacizumab is a anti-VEGF antibody, which is an anti-angiogenic drug, but it has an additional immunomodulatory effects also. So how it gives the immunomodulatory effects? Bevacizumab has been shown to promote dendritic cell maturation. It normalizes the tumor vasculature, and that's why it makes the more T lymphocyte to be going into the tumor. And it also affects the tumor microenvironment by inhibiting the immune suppressive cell like myeloid cell, stem cell, and the T cells, that is T regulatory cells, which is present in the tumor microenvironment, which suppresses the immunity. So bevacizumab has been shown to inhibit these cells also. And that's why these two combination was tried. And it was tried in first trial after the success in the phase 1B trial. So what we have here, we'll see in the next slides. So this is a slide showing baseline characteristics of both the arms. And if you see the various characteristics were fairly balanced, both the arms. So there was no chance of bias here. And the most important point I will highlight here is they have included very high risk patient. So if you see the extrahepatic extension, means extrahepatic disease, or the major vascular invasion, and the combination of both was seen in almost 77% of the patient. And this group of patient has a very poor outcome with any of the available tyrosine kinase inhibitor therapy. So now coming to the results of this trial. This trial was published in 2020, and the update was again published in 2021. So this is the updated results. If you see the primary primary endpoint, that is PFS and OS. So if this is the first, the Kaplan-Meier curve shows the OS data. If you see, the both curves are clearly separated from the beginning only, and the median OS with atezolizumab plus bevacizumab combination was 19.2 months versus only 13.4 with the sorafenib. So this is like HCC, where we are getting a median OS of 19.2 months is very encouraging, I think, for as a medical oncologist, because we hardly had any drug which could give us a survival beyond 1 year. And if you see the overall PFS also, the PFS was 6.9 months with the atezolizumab plus bev combination versus only 4.3 with the sorafenib. So now this group of high-risk patient that I already mentioned, it has included many high-risk patient, that is patient with extrahepatic disease or the major vascular invasion. So in this high-risk patient, if you compare both the drugs or both the regimens, so median OS in this high-risk group patient with the atezolizumab plus bev was 13.5 months versus with sorafenib it was only 6.1 months. So almost doubling of the OS was there, and even PFS was also significantly better. And now the overall response rate, we've seen with sorafenib the response rate again here 10%. So that is replicating here in this trial also. But if you see the response rate with atezolizumab, bevacizumab, again 27%. So it shows that the newer drugs are getting the newer regimens are better, and they are giving more response rate also. So now coming to the safety. So serious adverse event occurred more frequently in atezolizumab bev combination, that is 38% versus 30% with sorafenib. But if you see the treatment discontinuation, it was seen in only 15% of the patient with our combination therapy. That means if you manage this toxicity well, patient is less likely to discontinue. And one of the important side effects that is with bev is bleeding. So there were a few studies previously done with bevacizumab in HCC, and they have found that there is a risk of upper GI bleeding with bevacizumab, and because it is an anti-angiogenic drug. So what they have done in this trial, they have considered they did a upper GI scopy at least 6 months within the start of the therapy, and if there were any viruses, they have to be ligated before therapy studies to be started, so that to reduce the risk of bleeding. And that's why if you see the bleeding rates, it was almost similar. If we see the reflect trial that I have previously discussed, the grade 3, grade 4 bleeding was only 4%, and even in this trial it was only 6%. So if you manage you select the patient properly, you manage them properly, the risk of bleeding is also very less. So now this is a very important slide. This is the first line multiple phase 3 trial, and this is the second line. If you see various trial across the first line setting, only and only trial which has shown the OS benefit versus sorafenib in a first line setting is atezolizumab plus bevacizumab. So this slide actually slightly older, means 2021, but this was the only study which has shown a OS benefit, and that's why now it has become a standard of care. But again, the picture is changing rapidly. This year also there were few studies, positive studies. So my topic was future also. So I've included few positive trials here, which were discussed. This all discussed in ESMO 2022, just conducted 3 months back. So there's one more study of immunotherapy, that is camrelizumab plus ribociclib. So this is a tongue twister here, versus sorafenib as a first line unresectable metastatic RCC patient. So this is the study design. So this is a very busy slide, but I will just highlight the endpoints here. So these they have compared the two. That is here again, camrelizumab was immunotherapy and ribociclib was the TKI. So this is the immunotherapy plus TKI. So BEV was not TKI. That was a monoclonal antibody, but it is here the immunotherapy was combined with tyrosine kinase inhibitor with the again the old standard of care sorafenib. So this was a positive trial again. The PFS was here 3.7 month with sorafenib versus the experimental arm 5.6 month. And OS again, here you can see OS is even better here. So OS is I think here 22.1 month versus 15.2 month. So this is a trial which has shown the highest or the longest overall survival benefit with any of the phase 3 trial with systemic therapy in HCC. So this is just published, not yet available here in India, but surely I think that drug will come in next 3-4 years and may become standard of care. So this is the same thing conclusion. So next is the Himalaya trial. So I just wanted to ask this question just to make the atmosphere slightly light. So why the Himalaya trial, the durvalumab trial was named as the Himalaya trial? Can anyone guess? So what was the logic behind that, giving the name Himalaya trial to this immunotherapy trial? So I think nobody is oncology. So if you see various trials of durvalumab across the oncology, they were mainly named after the mountains and the oceans. So it was Pacific, Atlantic, like that. So that's why the trial was here actually named as Himalaya. Because I remember that because there was a lot of discussion in one of the CMEs that why it was named as Himalaya. There is no scientific background to that. So whatever. So this is again one immunotherapy study, that is durvalumab plus tremelimumab as a first-line treatment in patients with advanced HCC. So this trial included 4 arms. The 4th arm was closed prematurely, but 3 arms were continued. And if you see again, 3 arms were actually tremelimumab plus durvalumab as a side combination. Tremelimumab was given as a bolus single dose on first cycle only, and it was only durvalumab from the subsequent cycle. Second arm only durvalumab. There was no tremelimumab, and the third was sorafenib. And this trial was again positive. If you see the OS, it was better with the stride regimen versus sorafenib. OS with the durva alone was numerically better with sorafenib, but it was not statistically significant. So this is one more positive trial we have here. Now coming to the LEAP trial, this trial is negative actually. So this is a trial in the similar setting with lenvatinib plus pembrolizumab versus lenvatinib. So here the comparator arm was lenvatinib, which is slightly different with whatever studies. If you see the comparator arm was sorafenib, which was a previous standard. But now this is the only trial which has taken lenvatinib as a comparator arm, and the experimental arm was lenva plus pembro. So this trial was failed. So there was a lot of excitement about this trial because there was a phase 1b study, which has shown a significant OS benefit with this combination. And many people started using this combination also. But ultimately, when it came to the phase 3 trial, it was failed. So this was a big disappointment for all of us that this trial has not succeeded in its primary outcome. So now coming to the few last slides. So this is a recent HCC treatment option, systemic therapy. If you see for the PCLC stage C, the present recommendation is to use atezolizumab plus bevacizumab as a first line option. But if the patient is not affording for that, then you can use a lenvatinib or a sorafenib. And once the patient progresses on that, then you have multiple options in second line. Again, these are the ASCO recent recommendation. If the patient there is no contraindication for atezolizumab plus bevacizumab, first line option should be the atezo plus bev combination. And then post progression, you can use other TKI. If the patient is not fit or contraindication is there, then only you give TKI. So other than this, there are multiple ongoing immunotherapy trials, even in early stage in adjuvant setting. After these resections, these trials results are not yet out. Even there are trials undergoing for combination of TACE plus immunotherapy plus anti-VEGF. So these are the multiple trials like Emerald trial, which they are trying to see the outcome when they combine TACE with Durva and Bev or Durva. In LEAP 12, that is, they are combining TACE with Pembrol-Lenva. In Checkmate 74 study, they are combining TACE with Nivo EP or Nivo alone. And there were one more trial. So there are multiple trials, and I think once these results are out and if they are positive, so our treatment is again going to change in next near future. There are even multiple trials of CAR T-cell therapy going on in HCC, but these are in very early stage, preclinical stage, only phase 1 and phase 2. I think there is a long way to go before they comes in our routine clinical practice. And we need definitely more therapies for HCC because it is really a difficult disease to treat. So I will stop with a famous quote: "The future is not something we enter, the future is something we create."
Thank you, Samir, for sticking to the time. And the take-home message from your topic is past was nothing, present is so happening with land, and the future is with immunotherapy. So with this, we end up our session of presentations. And I request the audience to get to interact with the speakers regarding their questions. And we will have some 5 minutes to 10 minutes of the discussion, followed by a panel discussion.
This question, this question is for Tejas. The most important factor when we plan therapy in patients who have HCC is the cost. So the cost determines what kind of therapy we are going to offer. So can you please brief the cost involved in treatment in all the modalities which you discussed in the first session and multiple sessions required?
For chemoembolization, the cost involved is around 2 lakhs. And for the ablations also 1.5 to 2 lakhs per sitting. And for TARE radioembolization, the cost, as sir mentioned, it is beyond more than 10 lakhs.
Tejas, one question from my side. So how do you decide how many cycles of TACE and when to stop? And when you consider that now TACE cannot be done and you have to refer the patient to medical oncologist for systemic therapy?
So basically, after each session of immunization, after a maybe interval of 2 to 3 months, we perform a scan, see for any residual lesion or any recurrence also, and plan accordingly.
But how many total number of cycles can be tried? The patient is responding. Because there is one trial just published one last week. They have combined lenvatinib systemic therapy with TACE in BCLC-C patients. And that has shown us 6-month OS benefit as compared to lenvatinib only. So now TACE can be done even in a patient with histohepatic disease or a patient BCLC staging C, where only we are considering systemic therapy right now.
How will you go about it?
See, there are multiple studies already shown whenever it is the etiology is viral of means underlying etiology of cirrhosis, viral means post-necrotic cirrhosis, and now patient has SCC. First thing which we need to do is the patient should be referred to the hepatologist, start the antiviral therapy, because they have shown if you give both antiviral therapy and the systemic therapy together, they have better survival. So whenever a patient comes to me and I diagnose them that patient is hepatitis B or C positive, and now he has diagnosed with HCC. So before I start systemic therapy, I refer them to the hepatologist. I tell them start antiviral therapy, then I will start my systemic therapy. So that is the first point which is very clear. And if the patient is affording for immunotherapy, I straight away go for immunotherapy. If it is not affording, then only you have to go for oral TKI. So see,
you referred to a medical gastroenterologist for antiviral therapy. If the patient has BCLC-C patient, D patient, SCV positive, high viral, whatever tumor load is high, and you are expecting is 3 months survival. So no therapy has found to be an overall survival benefit.
See, basically, if it is child pox C,
yeah,
child pox C, so recommendation says no therapy.
Yeah.
So I'm talking about childhood A and B patients only. Maybe.
I should be very clear about it. Like, yeah,
Yeah.
should be very, very clear that a
obviously.
BCLC C patient, sir, if the patient is need some chemo, it is survival is the most important factor. Like what I think that
So
is
that
your
patient
question.
is likely to die because of cirrhosis other than the SCC.
Absolutely. That's why I was.
Can I see, many of the experienced people are here. So in clinical practice, if you get 100 hepatocellular carcinoma, I'd like to ask Ravi and others, how many are eligible for transplant, resection? How many are eligible for loco-regional therapy? I'm not talking about the patients who have come through the screening programs, because if you are coming through these screening programs, you detect the disease very early. So garden variety 100, are there any studies? We say that 40 to 50%, because in clinical practice, to get patients who are child's A having advanced disease, not that common. So I would like to ask that question. Secondly, what is the cost of immunotherapy? That's the second question.
About 10% patients with HCC are eligible for resection. Around 25 to 30% patients eligible for any of the loco-regional therapies or systemic therapies, because once they are B8 plus or C, child C, then none of the therapies they are eligible for. And transplant, about 40% patients are eligible for transplant when they come to us. But we also have a referral bias because we see patients who come to us for transplant. So at least in our unit, there is going to be a referral bias. But otherwise, 40% of the patients will be eligible for transplant.
Next is cost. So cost is actually definitely a very costly drug. Not many people can afford. With patient support program, we tell them to give, I think maybe 1+1 vial free or 1+2 vial free. It will come around 1.5 lakh per month.
And
So
how many sessions? How many months?
Patient has to take it till progression. There are few patients we have seen a patient of MSI colorectal cancer. There is one patient of mine, squamous carcinoma ureter. These MSI. They are taking the one patient has completed 2 years of therapy and is complete remission, metastatic stage 4 cancer, complete remission. So we have stopped it after 2 years. So there is a data which suggests that if the patient is in complete remission or very good response and immunotherapy patient has been taking for 2 years, we can stop at 2 years. But technically it is still progression.
So I would like to make a comment on what Sir has said. For every, even for child C cirrhosis or for a severely decompensated patient with HCC, with similar characteristics, transplant will always give a better survival benefit than any of the therapies. So every patient who has a good performance status, whose lesion is like within UCSF, he should be given an option for transplant. Even now, there have been many papers in which outside UCSF, I'm talking about, not talking about Milan, I'm talking about UCSF, more than 8 centimeters tumors. In those patients also, liver transplant is giving much more survival than all these therapies, all these systemic therapies, everything. I have not seen a patient who is a 2-year systemic therapy. I've never seen that patient, but I have seen patients who we have transplanted, who the tumor size was 10 centimeter. We have transplanted him and he is now survived for another 3 years. So every patient should be given a chance for transplant.
One point here, quick point. I agree with Rahul. So, like again, I'll reiterate the same point. So with all these therapies, we are looking at 1 year, 2 year, 3 year. That's it. The best systemic therapy gives you 22 months, which is also not released in the market yet. But even with patients with advanced portal vein tumor thrombus, which is considered as very advanced stage disease, with external beam radiation and TARE followed by transplant, the 5-year survival now is 65%. So therefore, there is emerging data that ultimately that goal you have to try to reach, because and then there are all these therapies are going to help you reach that. But if you fail, then if you succeed, then their benefit is there.
To add to both of this, what my boss used to say that SCC is a fertile soil theory. If you do remove one thing, the soil is there, the liver is there who can produce a next lesion. So you have to change that soil, you have to change that liver, then only you can survive, do a good survival. Two more questions from the chat session, if we can go ahead. So one question is from Dr. Ramlingam Rajendram. He asked about a non-cirrhotic liver, a typical SCC on imaging, SBSAG positive. Did we need a liver biopsy to diagnose a SCC? So I think the answer is there.
Non-cirrhotic, but typical features of imaging. Yeah, no biopsy. No biopsy.
And the other question is from Dr. Ramesh Rajan Nair. He asked about SCC with cirrhosis with hepatitis C virus with single lesion, whether to go for TACE or TARE, and whether that anti-SCV treatment should be given.
So HCV is out of equation. It should
Yeah.
be treated. But TARE has been proved in multiple studies to be superior to TACE in terms of durability of response. But then it's much more expensive. That's the only.
And actually, TARE has a better role. Actually, the TARE has a very specific or very proven role in portal vein tumor thrombosis.
Exactly. But the thing is that in countries where they don't have to worry about money, almost 90% of loco-regional intravascular therapy is TARE now. So in the US, TACE is less common. TARE is like rampantly being used because they don't have to worry about money.
And also for anti-SCV treatment, for early stage tumor, better to go ahead with all the resection, ablations, and then to start an antiviral therapy. We can start 3 to 6 months also later down the lane. And for, as already we discussed, of BCLCC, no advantage. For intermediate stage, there are some criteria. If the waiting period is much more, downstaging has to be much more, then in that case, we can start an antiviral therapy. So first to do whatever best you can do for a tumor, and then to worry for an anti-SCV treatment. That is the bottom line for treatment of anti-SCV.
Yeah, I think I think there are several new discussions today, and thank you all the speakers for bringing all these points to our attention about external beam radiation therapy, which is really under discussed, so to speak. And also, I think historically a combination of IR therapies with systemic therapies has never proven any benefit, but it's encouraging to see several new developments where IR with systemic therapies have now shown some benefit, and great to see so many new drugs coming along the way. So thank you. I figured I'll just thank all the speakers for enlightening us with all these topics and developments. I think what's really important is to recognize that, I think as Sir mentioned, we also forget the performance status of the patients. And unfortunately, the multiple cancers that we see are, yes, while it's fantastic to see them undergo transplant and survive, unfortunately, many of them are elderly patients who have poor performance status, other comorbidities. And then apart from that, the cancer and the decomp cirrhosis background becomes a big challenge for them to undergo transplant. So I think, as Sir was also saying, I think a lot of our patients either have problems with performance status, or certainly they're outside the criteria to undergo HCC downstaging as well, and effectively get them to transplant. I think that's the barrier. But the most important thing is screening, and I think most hepatologists should be doing it, and that should be done on a consistent basis, as that has truly proven to survive, to have more survival for patients.
Next, we'll have panel-based, case-based panel discussion. And the panelists for the discussions are Dr. Shrikant sir, Dr. Saurabh Mukewar, and Dr. Mayur Gattani.
So there is one online question. I think that's a fairly interesting question. Any data on response of fibrolamellar HCC to systemic therapies? I think Samir can answer this.
So no trial has specifically addressed patients of fibrolamellar HCC. So we have to extrapolate whatever we have to that patients also. You may not get any specific data for fibrolamellar HCC.
Yeah. So good evening. I am Dr. Mayur Gattani, gastroenterologist. So after these knowledge enhancing presentations, I would like to discuss one case managed at Midas Hospital. and the routine treatment dilemmas that we have managing hepatocellular carcinoma. And I would like to have our expert opinions on the dilemmas. So our case histories, we had a 62 years old gentleman who had history of hypertension, diabetes, coronary artery disease, and had ethanol related compensated liver cirrhosis for last 5 years. So he was diagnosed with hepatocellular carcinoma in June 2020, and we had a 10.5 centimeter diameter mass predominantly in segment 4 of his CT scan. So question here for the surgeon and the gastroenterologist in the expert panel. Sir, is this HCC unresectable? Yeah. 10.5 centimeter diameter, predominantly segment 4, no portal vein thrombosis, and so patient has CTP score of 7B with ECOG performance status of 0 to 1. No esophageal, no varices, CTP 7B. No esophageal varices, fibroscan 24 kilopascal. So is this
If we
HCC
go by
unresectable?
traditional criteria, then this will be an unresectable HCC.
Yes, sir.
But if we slightly extend the criteria,
Yes.
then
So by which criteria? Then 10.5 centimeter.
okay, this is not on a not on background cirrhosis. There is no.
So there is compensated cirrhosis.
This is not a transplantable, but a resectable tumor, of course.
Okay.
There is no vascular invasion, right?
There is no vascular invasion, but patient has compensated cirrhosis, and yeah.
Size is never a criteria for.
No, as long as you spare behind 40%, that's all. Nothing else.
Okay. So this question has already been answered by Dr. Ravi Mohanka, sir. So how would you approach this patient, sir? So as per the panel consensus, patient is resectable at present. So there are no downstaging or bridge to transplant is required in this patient, sir. Any bridging therapy is required?
I think the first question really is this patient having cirrhosis at all?
So-
So when you're discussing, I think, transplant, we should be thinking of cirrhosis first in the background. If the patient has a non-cirrhotic liver, then primarily resection is the treatment of choice. I don't think transplant should be a consideration, not for a non-cirrhotic liver.
So
Case where FLR is not adequate then.
yeah.
This case, there are a couple of things we need to know. One is if there is compensated cirrhosis, which you said,
Yes.
then how bad is it? If there is, first we'll do an endoscopy.
Yeah.
If there are obvious varices, then this patient will decompensate if you do a resection.
Yes, sir.
If there is no varices,
Hmm.
then you do a HVPG. If it is more than 10, then again the risk of decompensation is very high.
So I would like to add some investigation, sir.
Ah.
So serum alpha beta was more than 1000. CTP score was 7B. Performance status was 1. Fibroscan showed 24 kilopascal, and endoscopy showed small esophageal varices.
Yeah. So this patient is likely to decompensate.
Yeah.
So therefore, now resection is a risky proposition. So we should start thinking about transplant, but then he's out beyond criteria. So we should downstage him first.
Okay. So what are the options for downstaging, sir?
The ideal is TARE in this case because it's the large size of the lesion.
In Indian settings, the real world scenario, our patients are not
Yeah.
affordable for TARE. Then what should we do?
No, I think again, something everybody's not very familiar with SBRT. What's
such a large lesion, it wouldn't be amenable to TACE or TARE also. 10 centimeter is a big lesion.
Yeah, I think TACE is also going to be a challenge, but SBRT is, does it give you similar result as TARE, Dr. Mohanka, or do you think it's less than TARE?
To TACE, but then in absence of TARE, you can use SBRT, but not alone. SBRT alone is very poor, so you have to combine it with TACE.
Okay. So in real world scenario in June 2020, so we had the option of only going ahead with TACE. So we went ahead with that TACE, and I would ask the interventional radiologist here, what is the average number of TACE or ablation that can be done in this patient before proceeding to any further therapy? So Dr. Tejas had already answered this, that he said 3 to 5 sessions are required. But as per many guidelines, like they mention at least 2 or 3 sessions, and then after that they can the lesions are refractory to TACE if they are not decreasing in size. And is there a role of SBRT? So as sir said, there is a role of SBRT, but not in real world scenario. So question for oncologist here. Do you think the addition of systemic therapy with TACE would be helpful in this patient at this point only, before starting TACE? Okay. Shrirangwar, sir.
Basically, if the intent is bridging through transplant, then I think no. But if it is in a setting where transplant is not a further plan, so in that case, you can consider adding lenvatinib with TACE, or even there is a data for sorafenib also, but lenvatinib I think better. In that case, you can do, but specifically you have to start lenvatinib 14 days before the TACE.
Yeah.
So that trial has specifically mentioned that if you start after the TACE, it is not that effective. You have to start before the TACE, give 14 days of systemic therapy, then do a TACE. So that is better.
Okay. So we went ahead with TACE. This patient was offered TACE twice at a gap of 3 months. And post TACE, the CT scan revealed this. The diameter of the lesion had not decreased much in size, though there are some unenhancing areas in the CT, but this is suboptimal response. So my question to the house is like, is this suboptimal response after 2 sessions of TACE, or is this TACE tumor TACE refractory? So I would like to ask the interventional radiologist and the oncologist in the house. Will you go ahead with further sessions of TACE in this patient? So he had already undergone 2 sessions of TACE and the lesion had not decreased much in size. So will you still go ahead with further sessions of TACE? Okay.
What is the AFP value?
Sir, AFP value at the onset is more than 1000. No, sir. Yeah. Not coming.
Also, this is an unusually large tumor, and generally we see that in the EASL guidelines, at least the contraindication of TACE was a tumor more than 7 centimeters. Correct me if I'm wrong. So in that case, so did you have to use a higher dose of chemotherapy for this large lesion, and how many vessels did you embolize? Okay, that's it. So, but then if you were the one doing this case, so would you embolize like multiple vessels and use a higher dose? Obviously you would, right? And for TARE also.
We take the catheter to a point where the entire tumor is involved. The vessel at a level where entire tumor will be will get embolized. So in TACE or TARE, it will like encompass the entire tumor, not selectively a partial lesion. No, mechanism is different. Yeah, but anyways, we have to take the catheter up to the point. It is a super selective embolization.
The main issue here is there was no availability of TARE at that time, or at least today also, due to the cost. So what next for this patient at this point? So should we switch from loco-regional therapy to systemic therapy at this point because of non-availability of any other options? So I would like to ask Dr. Mandania, sir, what is the opinion at this point?
What was the opinion of the surgeon at that juncture?
Sir, he did not want to resect this tumor.
So I think we are left with a very limited option because
Yes, sir.
considering the financial constraint and all this.
Yeah.
And if you talk about the financial constraint, that means immunotherapy is automatically gone here.
Yeah.
So now we are left with the 2 options, that is oral sorafenib and lenvatinib.
Okay.
Means if you talk very clinically.
Sir, still, but as Shrirangwar sir had said, the list of negative trials with systemic therapy is too long. So should we go ahead with sorafenib in this patient, or let him manage some money and then go ahead with immunotherapy because the lesion has not decreased in size?
See, when we talk about immunotherapy, we need to be very clear that it is not a short-term thing, because if you are going for 2 or 3 cycles, it is not going to work here only.
Okay.
So if you are talking, at least we need
Still
to go for
compared
6
to
to 8
TARE,
cycles,
still compared to TARE, the immunotherapy cost as such in our discussions is less.
No, a single cycle is going to cost you approximately 2 lakhs. And if you're going
72
with the
lakhs.
6, yeah.
With nivolumab also.
And Neo also, yeah. And
Okay.
I think
Unless and until then it is available in some trial or anything, we can't go ahead with
anyhow,
it.
if you want to see a visible and clinical response, at least they need to have at least 6 months. Okay. Because if we talk about 2 or 3 or 4 doses, it's not going to show any visible response.
Okay. So fortunately for
Immunotherapy, sometimes we see hyperproliferation also.
yeah,
So initially because the tumors become inflamed with the T cells, sometimes there is a pseudo progression or hyperprogression and they respond later. So that's why there is a different RECIST criteria, I resist, for a patient started on immunotherapy. So that's why immunotherapy never see results in 1 or 2 months, wait for at least 3 to 6 months. You are not going to get rapid results.
yeah. So this patient was fortunate enough to get enrolled in a trial of nivolumab. So I would further like to ask the oncologist, like, would we have switched this patient from loco-regional to systemic therapy a bit earlier? Like, just after seeing the 10.5 centimeter diameter lesion, would we have started the systemic therapy at the onset only before going ahead with any loco-regional therapy?
So that this patient is for loco-regional therapy, but you are saying whether we should
At upfront.
Yeah, we can add. We have a data for that.
Okay. So you would have considered that. Okay. Adding to TACE. Okay. So we started this patient on nivolumab. After 3 cycles, the patient was evaluated with CT scan and the size of lesion was decreasing. Alpha fetoprotein was also coming down from 1054. It has come down to 247. And so in this way, we continued the patient on nivolumab for up to 11 cycles. But after 11 cycles, unfortunately, the patient developed obstructive jaundice. To know the cause, we went ahead with an MRCP, which showed the lesion increased in size and compressing the biliary radicals. So what might be the reasons for this?
So AFP was coming down.
AFP was coming down on first CT. After 3 cycles, the lesion was decreasing size. But after 11 cycles, the patient had come with this.
See, pseudo progression or hyperprogression is generally seen within span of initial 3-4 months.
Yeah.
So this patient has already
Is
gone
after
beyond
11
that.
cycles, sir.
So this is we have to take it as a progression.
So this might be considered resistance to nivolumab.
Did you did a CT scan at 6 cycles?
No, sir. At 3 cycles, it was done and then continued with 11 cycles. So unfortunately, the patient was not ready for any intervention after this issue and the patient succumbed. So this is what a case we, the dilemmas in the case we managed at Midas Hospital. Thanks.
11 doses. Not
Yes, sir.
exactly. Typically, they get a mess. 4 cycles, 3 months. 4 cycles. Second case in the
Yes, sir. Immune-related adverse events are known after starting of immunotherapy. So as sir said, the if the patient having any autoimmune disease already, it may get flared up. Or because immunotherapy leads to increased T cell activation in the body, so all the immune-related adverse events will increase after starting of immunotherapy. So just like iris, immune-related adverse events are present in this patient. Sir,
Yes,
might
steroids are the first line management for immune-related adverse events because of immunotherapy. And even we are using in one of my patient, I've used infliximab also when they were steroid refractory. So the management of immune side effects because of immunotherapy is similar to whatever autoimmune disease we manage. So they are very well known. I had a patient of ILD because of immunotherapy. There was one patient of colitis also. So sometimes they have a very bad ILD or colitis because of which they can die also. So, but the incidence is only 5 to 10%, and they don't occur immediately. They generally, there is a timeline. Means if you see some of the immune side effect occurs between 3 to 6 months, but generally like colitis, pneumonitis, or like even hypophysitis, pituitary means like endocrine, they generally occur after 8 to 10 months of therapy. They don't occur immediately. So we have to monitor them. We have to do the test in between.
Okay. One question to Dr. Ravi for this case scenario. Sir, would you have given, if this patient would have come to you, then was liver transplant an option for this patient?
Not upfront. this patient would have recurred, high chance of recurrence.
After 3 cycles, when the size was decreasing?
But it never came into the criteria. It never came within the criteria. So he was never a transplant candidate. But if it was feasible, I would have offered TARE to this patient. And if he had responded and wait for 6 weeks minimum to 3 months ideally. And if the disease remains stable for 3 months, then I would have offered him a transplant.
Because he survived for 9 months, like
No.
11 cycles.
So that is the average survival if you have done, even if you had done nothing. If there is no varices, then yes.
Yeah, thank you.
Actually, one more point to be mentioned in the case was the AFP levels above 1000 in a setting of a large tumor with a high AFP level. The recurrence rates are extremely high. So if there's something called a metro ticket criteria for HCC, in which if you have 1000 and above AFP levels, you should not be considering these patients for transplant at all. So.
Good evening. I'm Dr. Rajesh Chandra, medical gastroenterology, working in Midas. This is a commonly encountered, actually it is a hypothetical case, which is commonly encountered. 54-year-old male, comorbidities of diabetes and hypertension for last 15 years. And he was diagnosed to have cirrhosis, which is compensated etiology of NASH with child B, and on ultrasound showing a lesion. So CECT abdomen was done, which is showing a 4.5 centimeter LR5 lesion with no satellite nodules associated with thrombus in the right portal vein, with no metastatic disease and AFP of 200 with ECOG score of performance status 1. With this history in the background, it will fit, according to the guidelines, it will fit into the BCLC at C advanced stage. But I would like to ask Dr. Ravi sir whether we will offer the patient liver transplantation in this patient.
So is that tumor bland or a tumor thrombus? Is the portal vein thrombus bland or it's a tumor thrombus? So no transplant for him. And this is in main portal vein or segmental?
Right portal vein.
Right portal vein. So no transplant for this patient.
So
unless they are successfully downstage.
Will downstage and do the transplantation, or transplantation is out of
No, if they are upfront, no transplant. But if we downstage, which is successful, and there is a waiting time of at least 6 weeks to 3 months, and if their disease remains stable without loco-regional therapy for those 3 months, then yes, transplant.
And as we know, we are moving towards from the size of nodule and the number of tumors towards the tumor biology. So what, how you will see the patients, only AFP or anything else? Will,
so unfortunately, in this case, although the tumor is advanced, the AFP is only 200.
Yes.
You know, this, if the AFP was 1000, it was an easy decision to make. I would also do PIVCA2 in this case, because in some cases that are not AFP secretors, PIVCA2 is sometimes very high, like in lakhs. So that may be another marker which is reliable. But the most important marker of biology in this patient will be response to loco-regional therapy. Okay. If they respond to loco-regional therapy, then whether there is AFP response, PIVCA2 response, or size response, then I think that they have good biology.
And I would like to ask Dr. Tejas sir, what is the role of SBRT and TARE in downstaining these type of cases where portal vein thrombosis is in the background? Only TARE is better than TACE, or like?
Contraindicated. So TARE only remains the treatment of choice, and along with SBRT.
So portal vein invasion is not absolute contraindication, but it is a relative contraindication if it is a minor involvement.
Yes, and if the tumor and probably that if the tumor and the involvement of the portal vein is in the same lobe, and the contralateral, the other lobe is the portal vein in the other lobe is patent and not invaded, then probably we can go ahead with TACE also.
Yeah, I think the general understanding was thrombus does not impact TARE,
yes,
but it does impact TACE.
Yes.
Unless, as you said, in a specific scenario where the that particular area is not thrombosed and the other vessel is there. But TARE is open, is okay, can be done, but not TACE, right? So I think that's the message.
So with this discussion in the background, is the vascular invasion indication of systemic spread? And there is a metro ticket calculator which was showing a 45% of patients have survived 5 years with a 6 centimeter lesion in the with vascular invasion. So the study was in 2009. So the patients with even with vascular lesion, some patients have a survival. And there is some more data. Macrovascular invasion is not absolute contraindication. This study is from South Korea, where they have retrospectively studied the LDLT patients who have undergone 11 patients who have undergone LDLT without downstaging. Even then, the 5-year survival rate was 63.6%. And the risk factors for recurrence, which was found, was main portal vein invasion, AFP into PIVCA-2 score, and high uptake ratio in PET, and large virginal tumor. So the conclusion was, if the portal vein thrombosis has not expanded to the main portal vein and AP score is not high, we can consider LDLT as a curative treatment option. So this was a recent study. This was an Indian study from Medanta. Which, they have taken around 25 patients where they made a protocol with excluding the extrahepatic spread, and also they have excluded the portal vein thrombosis was classified with VP1 to VP4, with VP4 as a main portal vein invasion, and they have done the TARE with SBRT, and then they proceeded with response, and they have given prior sorafenib also. The downstaging, the results were shown in this picture. As we can see here, the 5-year survival rate was around 53% in selective patients. And the conclusion was HCC patients with portal vein thrombosis can achieve acceptable survival with LDLT after successful downstaging. And the poor prognostic indicators were low initial AFP levels, a significant drop in AFP, high good prognostic markers, low initial AFP level, a significant drop in AFP with downstaging, and low grade tumor initially. And so the take home message is, not all the patients with portal vein thrombosis are included in advanced stage, and given the systemic therapy, they can offer, if we work up meticulously with tumor biology in the background, we can offer liver transplantation with downstaging. And multidisciplinary approach with can help personalized therapy to obtain optimal outcome. Thank you.
Okay, so that brings us to the end of the presentation today. I know everybody's desperately waiting for the drinks and dinner. So I would like to thank all the speakers, starting with Dr. Ravi Mohanka, who's come all the way from Mumbai and delivering the talk here. Thank you, sir. And I would like to thank Bhushan and Tejas, as well as Samir, who have done a very nice overview on the topic. And then I would like to thank all the chairpersons, Dr. Saxena, Dr. Gulane, Dr. Mandania, Dr. Sundaram, and Snehal. Hi, thank you. And last but not the least, the sponsors for the event, Roche, who has been very kind, and they have been wonderful in terms of organizing this event here. So thank you so much for all this. And I think we all got to learn quite a few things today. Hepatocellular carcinoma is not something that's discussed very routinely in such a detailed manner in most events. So today we could understand the developments, and for a person like me, I was being fairly in the thick and thin of things with all this management. Even in the last couple of years, these developments are something new, especially the new BCLC guidelines, the role of SBRT, the combination of systemic therapy with IR therapy, and several new developments like transplant for portal vein thrombosis as well. So thank you, everyone. And I would like to invite you all for drinks and dinner. Thank you. Yes. Sorry, the Roche team would like to say something. Yes. Let's say, yeah. And I think the Roche team would also like to communicate that immunotherapy options are available for patients at a much lower cost than what's been discussed here.
Hello, everyone. We would like to have a bouquet presentation by Dr. Shrikant Mukewar to the chairpersons. I would request Dr. Sushil Mandhania to please come over. ताली बजाओ. I would request Dr. Rahul Saxena to please come over. I request Dr. Snehal to please come over to the stage. I request Dr. Mohan Sundaram to please come over to the stage. Dr. Amit. Thank you, sir. I'm Dr. Jyoti Podar. On behalf of the Roche team, I thank Dr. Shrikant Mukewar, Midas Hospital, for giving us a platform to host, to be one of the hosts of this event. Thank you, sir. Looking forward to many such meetings.